I'm Peggy Nestor. I'm also a conference planning committee member, and I'm so happy this afternoon to introduce Dr. Mark Cucuzzella and grateful to have him join us today from his home in beautiful West Virginia. Dr. Cucuzzella is board certified in family medicine. He's assistant professor of medicine at West Virginia University. He's a retired Air Force Reserve lieutenant colonel, an avid runner and advocate for getting out in nature. Type 2 diabetes, it's epidemic around the globe. It affects nearly 500 million people now, growing rapidly. It has long been accepted that it is a chronic, progressive, and incurable disease. This afternoon, Dr. Cucuzzella will present the latest science and research in his talk titled Type 2 Diabetes Remission, Fact or Fiction. We will defer questions until the panel, which will follow immediately after his talk. So please welcome Dr. Mark Cucuzzella.
Certainly, it's a privilege, Alyssa and Peggy, to be presenting here to your group. I'm sitting here in Canaan Valley, West Virginia, and it's a beautiful place, not actually too far from where you are in Yellow Springs, which is one of my favorite places in Ohio. Spent many years of my reserve career at Wright-Patterson Air Force Base, and being a lover of trails, there's some of the most amazing trails in Yellow Springs. So maybe one day if we do a live conference, it's like a little earthy enclave, near, $1 billion Air Force base. So I would love, getting, driving 20 minutes away when I was on the base and be able to get some coffee and a run in Yellow Springs. But yes, what I'm going to talk about today is diabetes remission. Is this a real thing? When I started medical school 30 years ago, diabetes was this chronic condition, and we didn't even think that it could go away. But I think now, with experience of patients and the science finally catching up with the experience of patients, science travels late in the game when patients are making change. We're now accepting that this should be a standard of care. So I'm going to go through a little bit of the science, a little bit of the practical too, and even if we have some time, I have about 30 different case studies on this of patients I see. Maybe we could choose one or two of them, or even talk about that a little bit in the chat. But I want to keep this pretty informal. So if you have a question, you could throw it in the chat, and then we could catch it later, as we do the session from 4 to 5. And I really appreciate Vivian. So I'm going to kind of briefly kind of cruise over things she covered, because Vivian and I know Vivian just through the internet and sharing emails, that we're very aligned in what we're trying to do to give patients hope and restore their health, not just manage their disease. So I really thank Vivian, with her presentation. So next slide here, objectives, so understand some of the key features of what's the insulin resistance metabolic syndrome. How can we reverse this? A little bit on the science of low carbohydrate diets, and we can touch on this because I think it's important. I just got a textbook chapter and a paper accepted on medication reduction, with low carbohydrate diets, because we learn in medical school thousands and thousands of hours on how to prescribe medications, but I don't think I had a single talk on how to deprescribe medications in all of my training. So I hope in the future that taking medicines away will be just as prevalent as adding more medications. Disclosures, I don't have anything really to disclose other than I own a small running shoe store in West Virginia that opened to really support a nonprofit where we're building trails for kids in schools. And I'm a director of what's called the Low Carb Action Network and a founding member of the Nutrition Coalition. And these are advocacy groups where our primary purpose is revising the dietary guidelines for America. I also work as a science advisor for Diet Doctor, which is a wonderful site with no commercial interests. We all believe in physical activity, and I love physical activity. And I was the medical director of a conference called the Southern Obesity Summit, 18 states, all in that stroke belt, obesity belt, cardiovascular disease belt, pretty much poverty belt. You name the condition and it all travels, in the Southeast. There's this whole belt from West Virginia down to Mississippi. And I kind of just snapped this picture. I thought it was kind of humorous. We're at this obesity conference and everyone's taking the escalator down. And this is what you see at airports too, right? No one takes the stairs. Everyone just, after you've been sitting on a plane for 5 hours. So maybe next time you're looking at this, you'll think twice about getting on the escalator. So I'm here today, and if you're a patient or someone practicing medicine in any scope, whether you're a health coach or dietitian or, nurse, we're here to bring people hope. Diabetes has traditionally been thought of as one of the diseases of despair. I mean, it's like, how do you get out of this? And it's just more tests, more drugs, more complications. But we're here to give people hope. This was one of my patients last week. If people actually understand this and get support, it's crazy what health benefits they can get. This is about 7 months on a reduced carbohydrate diet, focusing on healthy foods, 70 pounds gone, almost all of his medications. And able to throw away his CPAP. Basically, it liberates you and sets you free. You become a well person again. And maybe one day this wonderful gentleman who just retired, will die of natural causes. We don't see that anymore, dying of nothing, meaning you're a well person and you just vigorous up until the very end and you go to sleep and you don't wake up. But now that's pretty rare. We all die of something, and it's one of the conditions associated with insulin resistance. Prediabetes, I think, is just dismissed from what I see in my medical practice. It's just prediabetes, I'm borderline. Patients do not understand this, but the more pre-diabetic you are, the more diabetic you are. It's like a skateboard ramp, your cardiovascular risk. And it's a human right to understand this, because if you don't understand this and you don't understand it's actionable, and we're treating you as healthcare providers, it's similar that if, think about this, 25 years ago, there's the beginnings to be a cure for AIDS. We had powerful medications that could put, and giving out condoms, things that just prevented and treated AIDS. And what if people just didn't know about that? Now you think that's crazy, but it's similar, I think, with prediabetes and diabetes. There's such simple preventive and treatments, meaning most of the treatment is lifestyle, that makes this go away and makes it not happen to begin with. If you want to really look at how powerful this diabetes is to cardiovascular risk, this is the Women's Health Study. This was published a couple months ago, 21 years, 28,000 women. So what drives cardiovascular disease? So we all know if you got a little bit in your genes, your mother, your father had cardiovascular disease. This is kind of odds. So 1.5 odds, 50% increased risk if you have a first degree relative cardiovascular disease. And sometimes that's just because people in the same families might live the same, eat the same, exercise the same, or not exercise the same. Smoking, 4 times risk. That's legit, right? And every patient we see who's smoking, of course, we would tell them, to quit smoking if you want to decrease your cardiovascular odds. But look at this stuff, kind of going up the chain here. We got obesity, hypertension, and then this thing, Vivian mentioned, the metabolic syndrome, which is insulin resistance, 6 times cardiovascular risk. This is worse than smoking. And certainly if you have full diabetes, 11 times risk. So if you're walking around and you have type 2 diabetes and you're not aware that you have an 11 times cardiovascular risk, and we haven't told you, that's on us. We need to tell these folks. And look at the labs, right? So there's a lab study where you can actually measure through multiple lipid markers what your insulin resistance is. 6 times risk. LDL barely moves the bar, as far as your risk. And if you look at LDL, it's the small LDLs, not the large LDLs. So these small LDLs and total LDL travel with insulin resistance. The large LDLs are really a marker of health. So if we're focusing here on cholesterol, but not here, we're wrong. We have to rethink this and relearn it. Vivian touched on this: body mass index, fasting, insulin, systemic inflammation. They all travel together, so we should be looking a little more at insulin. And, Vivian mentioned the different ethnicities have different responses of this hyperinsulinemic, or non-hyperinsulinemic response to the resistance, which may affect when they become diabetic. So a lot to learn in this space. No one's testing insulin. But let's talk a little bit about epidemics and pandemics. So, I think the word pandemic right now is we're kind of done with hearing about that. But diabetes, and maybe it'll, the coronavirus pandemic will ultimately fade away. But no kidding, type 2 diabetes is not going away. This is a global pandemic. So kind of going down, Vivian showed the slide too, the prevalence of obesity now in America, this is the NHANES data. But what terrifies me, this doesn't break it out by ethnicity, this is total, is this group here, the 20-year-olds. So when people are entering young adulthood already obese, their odds of becoming a normal weight adult is near zero right now. So we're failing our children. We should, as a society, deliver kids into the world healthy. So they're developing these conditions in grade school now, and it is not the children's fault. You cannot blame an 8-year-old who's drinking chocolate milk at school, on that they're becoming obese because they just need more gym class. We know the metabolic drivers of obesity and the massive amounts of processed food and sugars that these kids get, in the guidance of the U.S. dietary guidelines is just, it's not acceptable. Yeah, around the world. So obesity is not just an American problem. It's even in developing countries. You have malnutrition and obesity in the same countries because the cheapest foods are the processed carbohydrates with added vegetable oils. They're the cheap foods. The cheap oils and the cheap flours and the added sugar. And those are foods of food stamps and poverty, and that drives obesity, and they're not nutrient dense. So there's no nutrients in these foods. So they're malnourished and obese at the same time. Pick any part of the world, and obesity is just going up like a skateboard ramp. Um, yeah, so projections are horrible because everyone is aware now that obesity is a big deal, but the numbers keep going up. So 2030, half of the U.S. will be obese. How do we bend this curve? We can do nothing. We could do little minor strategies, but it won't happen. So, this is a slide in relation to early coronavirus. You got to put the hammer down if you're going to blunt this. So, I wrote this in April of last year as a time to quarantine junk food, because we knew right away with coronavirus, the only people that hit our hospitals, and I was working in our hospital, were the people with comorbidities, and that includes children too. Marty McCary was on, he's at Hopkins. Doc's written multiple books, but he and his research team documented that there's not been a healthy child die of coronavirus. That's fascinating to think about. So if you're healthy, your odds of dying of coronavirus are near zero. We wouldn't have this going on if we had a healthy society. And if we had acted early in April of last year and put some resources into preventing diabetes, obesity, hypertension, cardiovascular disease. These are, every paper you read on coronavirus, these are the ones that put you in the hospital. We'd be looking at a different scenario now. And this is going to come around again. And Nina Teicholz and I wrote an article. Nina Teicholz is the author of The Big Fat Surprise. And it took us 10 months to get this article published. Is it time for a lockdown on sugar? And I can share that article with you later with the mechanisms of what happens in obesity and diabetes, that lead and drive to the cytokine storm and the faulty immune response. Why do people get sick? Even diaphragmatic function, if you've got a lot of visceral adipose tissue, so many drivers. So I'm a family doc, and I think, one of the beauties of being a generalist is, someone told me this when I was in my training, where the experts disagree, the ignorant are free to choose. So maybe a generalist, if you're a generalist out there, a holistic health practitioner, you could line up all the expert opinions. They all disagree. So yours is probably just as valuable, and have that beginner's mind. This is a really good book. It's called Think Again. It's by Adam Grant. He's a organizational psychologist, but he does his research really into, how the mind and intellect is working to shape behavior. But one thing I witnessed, I'm a professor at a medical school, been through the whole trail of everything in the academic, writing and promotions and, discussions and, all that stuff. But what we don't see is what's called intellectual humility. And I think that's where all of us here, I hope you'll leave this with some intellectual humility. I mean, there's a lot we need to know, and myself as a family doc, quite often in an academic environment, we'll get bullied by the subspecialist because, oh, you're just a family doc, right? You're not a cardiologist, endocrinologist, you don't really have, the right to be sharing this stuff. And, I'll back it up with, hundreds of papers that we can share, and we can have a nice intellectual discussion versus dismissal. So this today is a nice intellectual discussion because Vivi and I do not have all the answers. We're just observing things, reading things, researching things, trying to discover new things because, this is a pandemic which we have not flattened the curve. And I think you'll see this in really the practice of anything. It's called the Dunning-Kruger effect. and there's a lot of folks out there, probably, with really good heart, get a little bit of knowledge about a topic, and then they have high confidence to give advice. And you'll see this kind of with young medical trainees. Maybe someone says saturated fat is bad, and their patients are fully diabetic, and they'll tell them to have a lot of whole grains, and maybe that works for a certain subset of people, but they don't fully understand that that probably is not going to work for a diabetic patient. But they'll freely give that advice across the board, with good intention. And then, kind of the longer you go, you're like, oh wow, there's a lot I need to know about this, and it's complicated. This has been about a 10-year journey for myself, digging into nutrition and disease remission and low carb plans for diabetes and obesity. And I'll share with you later a little bit how I got into this space. But if you're in an environment, an academic environment, you see this happen. People fall into different camps and how they think. You have a preacher mode, someone just defending a sacred value. And you see this with the lipid hypothesis. Cholesterol causes heart disease. If you've spent your whole life advocating that high cholesterol causes heart disease, and if I lower your cholesterol, I'm going to reduce your odds and don't bother me with anything else, you're really defending that value, not open to discussion. Prosecutor is when you just basically want to silence people who have an opposing position, as if you're trying to win an argument. Politician mode, you see this a lot with young learners, if they're rotating with a senior doctor, so they'll just ally with the camp of whatever that senior doctor's way of practice is, because really they're just trying to kind of work their way through the system with the least resistance as possible. Then you got a scientific mode where we're always searching for the truth, so this is, I hope, where you all will be after this discussion. People will say this low carb way of eating for diabetes remission is an extreme diet. So this is kind of a little bit of the stuff I would eat. You can pause there. Does this look extreme, or does this look highly nourishing? I would hope most of you, if you're hungry right now, or be like trying to pick which of those you would want to eat. So yeah, no, this is not extreme. This is what we eat. Now, I've given talks all over the place on this topic. This was at a military conference a couple years ago, giving a talk on low carb diets for soldiers who are trying to lose weight, because they have to, military members need to maintain a waist standard and a weight standard, as well as a fitness standard. And this is what they had for breakfast, and there wasn't a single thing out there that I would eat. And certainly if you had a problem with your fitness test and obesity, I would hope that you wouldn't eat any of these things either. But this is acceptable food at medical conferences. I actually this was a grand rounds presentation, as well as for CDEs at a local hospital. And this is obviously sponsored by the drug companies, but they're, again, like a diabetes talk. This is what it's like, basically feeding us diabetes as we're giving the talk on diabetes. If you go into a hospital, and your doctor orders what's called a cardiac diet, say you had some chest pain. So the cardiac diet in a hospital won't have any fat in it. Now, no kidding, you just saw that diabetes is the biggest driver of cardiovascular disease. This has 200 grams of carbohydrates. Now, does this look good for your heart if you're in there with unstable chest pain? I would hope your answer would be no. If you are in a hospital and they just type in an ADA diet, for diabetes at 60 grams of carbohydrates, this is what you'll get. And if any of you, I've got a glucose monitor on my arm now, this would blow up my glucometer in a tenth of this plate. We've done some change, so be willing to, have, be the resistance, right? So yeah, so we got sugar drinks out of my hospital for patients, visitors, and staff. We actually got implemented in 2013 low carb menus for diabetes patients, so you can do a 10-gram carb per meal. And do these look like restrictive diets? People say, oh, that's really restrictive. Does this look restrictive, or does this look like a healthy meal? I would hope you'd say that looks pretty good, right? It's a healthy meal. And our dietitian made up a 7-day menu. This is what you would get. So this is not complicated to do. But again, you're fighting institutional entrenchment and dogma if you go into a big hospital system and want to suggest that they get rid of this, which is the reason that person is in the hospital, and feed them this, which eggs, eggs do not cause heart disease. And I think, if anyone wants references to that, they could just put it into their PubMed search. That's been debunked. Even the US government in 2015 in the dietary guidelines said fat and cholesterol are no longer nutrients of concern, meaning that cholesterol in the egg is not raising your blood cholesterol, and your blood cholesterol doesn't clog your arteries. It's not that simple. So not many people would actually be able to finish that meal right there, especially if they're, in a hospital getting treated for an illness. We have free drink options in our hospital, when we implemented this, just so the natives wouldn't get too restless that we took their soda away. We, have just like a hotel lobby. And we did this 4 years ago, and yeah, there's people are pretty proud of it, got rid of all these vending machines. We actually opened a clinic. I think some of the changes we were making in the hospital led to some innovation. So we opened a clinic where I'm actually allowed to prescribe eggs to people, at a university. This was a patient who put his diabetes in remission, pretty simple thinker, he's on, uses SNAP for his food costs, doesn't have a kitchen really, and can figure this out, so this is my state right here. It's West Virginia. We're outliers and being most of the time either number one or number two in the obesity and diabetes. It's one of the most recent data is from NHANES. We've got number one in diabetes. There's a lot of unique things to Appalachia too, and despair and poverty, and but that's another whole talk. Vivian mentioned this, so it's actually really rare to be well now. Only 12% of the population now is well, but you guys saw that with her presentation. Now the military, I spent 29 years in the military before I retired, but obesity is huge amongst active duty folks. So the Army, 69% overweight or obese. Marines have the lowest. It's 60% plus across the board. And as people get more senior in their career, certainly the BMI is not defining healthy or unhealthy obese. There are some younger military soldiers who certainly have high BMIs who I want to go downrange with, super strong, muscular body types. But as people go later in their career, they tend to look like the rest of the society around them. And so that overweight and obesity is not muscle. They're putting it on in the middle, in the belly. I'm on a couple working groups now, that are trying to, how do you make inroads into a military culture and what is served in chow halls. This is another article which also, defining this over fat and under fat goes to what Vivian was talking about. So we need to define who is over fat in the wrong place, not overweight, because if you're over fat in the belly, that visceral adipose tissue, and that ectopic fat, that starts to occur as people develop that visceral, that apple shape, that is the disease, and that's what we want to rid and prevent. So a little bit about how I got into this space, as a marathon runner. If you went and looked at me, you'd be like, okay, this person should not have these conditions. But I was 45 years old, on military duty at Wright Pat, and I had a high fasting glucose. People my age don't go to docs, but men especially, men do not go to doctors unless they're kind of forced to by, military standards. They have to do this every year, or employment physical, but men especially just don't go to docs unless they have a symptom. But my glucose was up in the 140s and my A1C was above 6. And it just seemed a bit unusual. So they ordered this test called a C-peptide, which actually measures how much insulin you make. And I was just making like a trickle. I'd never ordered that test as a family doc. I had to go kind of look it up. They had a research arm of their endocrine department. And then they put a continuous glucose monitor on me. They had back in 2012, 13. These were like pretty big and bulky. You had to download the data. But I was a runner, so I was, eating your carb heavy diet. And what I saw immediately was, half of that bowl of cereal I would eat would take my glucose up to about 250, but I was highly insulin sensitive. So there's a first phase and a second phase insulin response. So my first phase really was non-existent, but I had a little second phase, and then I would crash down. And I was the guy who'd be like hoarding muffins at every, the drug companies were always bring, all this stuff in, but I would hoard a bagel or hoard a muffin. I was waking up at 2 a.m. every morning, needing another bowl of cereal. And I just thought it was because I was burning a lot of calories. I was actually losing weight and eating probably like 8,000 calories a day. It was really bizarre. But as soon as I saw that data on what was happening with the glucose and the glucose monitor, I turned the food pyramid upside down like in a day. and was able to stabilize my blood sugar. But most important thing, like I hadn't realized what it felt like to not be hungry all the time and to have stable energy and be able to eat dinner, not have a snack at night like I was doing, which was a carby snack, and actually sleep through the night and wake up in the morning and actually be able to go for a run in the morning, and then come back for breakfast. It was new territory of something I didn't understand, and I brought that back, into my civilian job. Um, yeah, and the consequences in the military. So at that time, I had about 5 more years left in my career, maybe 6 more years. But if you have diabetes or you're on diabetes meds, you're discharged from the military, medical discharge. And I really loved what I did. Part of my job is training, these combat troops to run and move efficiently. Because these are like the human weapons out there, and these guys are like definite paleo warriors because they're doing low carb paleo diets. They don't even know what it should be called. They just know that whatever that cadre, that senior leader, hey, what do you eat when you're dropped out of a plane and you're not going to get picked up for 7 days? It's all fat and protein because those are the super nutrient, energy dense foods, and they need to run on fat, and it gives them mental clarity. And there's research now into actually supplemental ketones with these special operator type forces, because there's this special mental clarity that you have if you're actually in a healthy level of nutritional ketosis, and when you have to be fully aware of your situation at every minute of the day. Yeah, so figured it out, stayed in the military, and was able to retire without a medical board. um, what's changing now, I think, in diabetes care? So 2017, this is the standards of care, ADA: complex chronic illness, continuous medical care, multi-risk factors. Does not sound hopeful. Now we go to 2019, and I think this sentence is important. Reducing overall carbohydrate intake for individuals with diabetes has demonstrated the most evidence. Let's repeat that. The most evidence for improving glycemia may be applied in a variety of eating patterns that meet individual needs and preferences. This is about a 140-page document, but I wish this was known across the board to all healthcare practitioners. So if anyone now is recommending low carbohydrate diets for their diabetes patients, they're not out there rogue. This is in the guidelines as the most evidence. And if you want to come off medications, yeah, reducing overall carbohydrate intake. And that shouldn't be rocket science, right? If you want to come off your diabetes meds, you're treating the food with the meds. Stop the food. Yeah, I mean, again, read the article. It's diabetes care. Yeah, they kind of put it in soft languages. They never come out and say, well, we were wrong. It's always updating the guidelines. It always sounds a little more soft, but I don't think people really keep up with these papers. This lady's bold. She's the ADA CEO, and she went on a podcast talking about her low carb diet. Pretty much what a lot of this conference is teaching. Just bread's a carbohydrate, pasta's a carbohydrate, fruits. And she was able to put her diabetes into remission, toss the bun out. This is the ADA CEO talking about this. And who funds the ADA? Pharma, right? So she got a lot of pushback for this, right? Because the pharma is very happy to keep the status quo, and they'll give out these plates of diabetes diets with a quarter of it being grains. Because if you eat those plates that the pharma reps will hand out, you will stay diabetic. You will never make it go away, and that's good for business. And I'm not a conspiracy person here, but that's just the honest truth. Anything presented by pharma is not for public health. Any research done by pharma is not for public health. It's for shareholders' benefits, period. It is not for public health. Um, so the cost is staggering. The cost is staggering. Our kids and our grandkids, and even us if we're young, society can't afford diabetes. It's breaking the bank. The average patient with diabetes costs $17,000 per year, and that isn't even some of the other comorbidities which aren't considered diabetes. If they need a cardiac stent, the cost of care for healthcare of the federal budget is 2.9 trillion. 9.7% of our GDP now is healthcare. And we want to have good roads, we want to have good benefits, we want to have good schools, but the more we're spending on healthcare, that stuff's not going to happen. So let's talk quickly about, okay, can we make diabetes go into remission? And we know this is true, based on it, primarily right now, non-debatable, the first two methods here will make your diabetes go away. So if I take your stomach and intestines out, your diabetes goes away in a day. I don't say that disrespectfully, but that's true, right? If you come into bariatric surgery on 4 diabetes medications, they will stop them the day before surgery and probably not restart them because you're on like a liquid fast for 8 weeks. Or I could do the liquid fast. This is a study called Direct. They did a 12-week, 800 calorie a day protein sparing modified fast, which is high protein, low fat, low carbohydrate drinks. And they stopped when they did that trial in the diabetes patients, all diabetes medications stopped at the onset of the trial. Now, some might have needed a little bit added back, but the majority, they never needed them back while they were on that diet. Now, the low carb diet can also put diabetes into remission without either of those two top ones there, which I believe are more extreme than eating salmon, salads, eggs, meats, which sound like delicious foods. The research has been there. Virta Health is probably the lead in this area, Virta. And if you just go onto their website, they've got a number of studies published. I've got databases of studies on this too. So usual care, diabetes will not go away. So if we just do the status quo and tell people to have 60 grams of carbohydrates a day, it will not go away. I mean, shouldn't be too surprising. What got you there will not make it go away. So diabetes control has stalled across the US for all of this increase in cost and more medications. We're not doing any better with diabetes care and control in A1Cs. So we're doing something wrong, spending more, doing worse. So we have to relook at it and not keep doing the same thing. So I'm not going to go through these slides, but these are just showing you the data on these different methods. This is low calorie diets with protein sparing modified fast. Now that to me sounds pretty extreme. Not many patients in rural West Virginia are going to be willing to do 800 calories a day in shakes. Like just the thought of that is setting their stress hormones up. But low carbohydrate nutrition, which is mostly a ketogenic style diet, there's not a keto diet. Nutritional ketosis is a metabolic state, meaning as your body starts to mobilize and oxidize fat with that low insulin state, you start to make ketones through your liver. So there's not like on the web, there's a keto diet. No, that's not true. Your body makes ketones if you're in the correct metabolic state. And I don't have people here in West Virginia measuring ketones. I just try to get them to understand the foods that will allow them to access their body fat. Yeah, so about 60% of patients who do this will be off of all of their diabetes medications other than metformin, and have their A1Cs into a non-diabetic range at 2 years. This is the Virta trial. And what is low carbohydrate nutrition? Because if you read the literature, there's studies that'll call a 40% carbohydrate way of eating a low carb diet, but that is not a medical low carb diet. So really these people that are so severely obese and insulin resistant, you've got to get them really low, less than 30 grams a day in their induction phase, because their liver is just so chock full of fat. That takes a little bit of time. Then maybe you can kind of go up into this space a little bit, 50 to 100. But if they're at 30%, the average American now has, it's like 250 grams of carbohydrates a day. So that's just phenomenal amounts of carbohydrates. But so 150 might be considered low, but it's not low enough to get the insulin low enough to be able to release. Insulin's a fat trapper. So it's like a dam. You got to get it low to be able to release the body fat. Troublemakers, so maybe some of you out there listening are a little bit of a troublemaker, good trouble, right? So in medicine, we really follow this consensus opinion, and if the consensus agrees the consensus is right, then nothing ever changes, so if you're willing to defend yourself, with the evidence, with how you live and how you practice, feel fine to be a little bit of a troublemaker and a dissenting opinion. In the Supreme Court, Ruth Bader Ginsburg was the dissenting opinion. The consensus makes better decisions if you have a good dissent, to be able to challenge the consensus. And then maybe the consensus opinion is right, but we haven't had good challenge to consensus opinion. This was a presentation I gave for a group of spine surgeons, National Academy of Spine Surgeons. So they're not allowed to do elective spine surgery now if patients' BMIs are greater than 40 and their A1Cs are greater than 7. So this is Carrie Deulis, one of the first female spine surgeons ever trained. She's a type 1, Andrew Kutnick's a type 1 diabetes patient. And Jim McCarter was one of the founders of Verta. And I work at WVU alongside a lot of our surgeons. So the surgeons are very interested in how do we get these patients, because they want to help their patients, but if their BMIs are 50 and they're fully diabetic and they need spinal surgery, until they can get those parameters improved. So they were very interested in what we presented, and we had an hour presentation, and they kept us an hour at lunch for Q&A. And that was just refreshing, just hearing just the empathy of these physicians just wanting to help their patients, and how can we do this in our clinic. And what I kind of came away with, in which I see my own practices, is our patients need support. And Vivian mentioned that too. So you could make some protocol guideline food lists, but if people don't have support, whether it's from the medical side or at home, it's very difficult to do. So if you're in practice now, support your patients, reframe type 2 diabetes. Previous, this is a progressive disease, lots of medications, lots of complications, it's despair. But if you can get your patients to believe that they can make this go away, and this lifestyle change is sustainable for the rest of their lives, you can get the medications away, prevent complications. If they leave that office and if they can affirm that they think they can do it, then they have a chance of doing it. If they don't think they can do it, they don't know about it, their odds of doing it is zero. And it's just like any condition, they're going to relapse. They're going to fall off the rails a little bit. I'll use this phrase with people, this from Richard Bernstein, everyone's fear factor of all your diabetes complications. And that's a lot of the screening of diabetes. Get your foot exam, get your eye exam, get all this screening for the complications. But well-controlled diabetes is the leading cause of absolutely nothing. Well-controlled diabetes is the leading cause of nothing, and that gives patients hope. But this diabetes is metabolic disease. It's just one of the arms of the branches of the weed. But think about it, in 1 minute, write down all the diseases that are now common that would have been rare 100 years ago. It's probably some of you yourselves or your loved ones have a multitude of these, right? You got them all, right? These are the metabolic syndrome, insulin, high insulin state problems. It really starts in the liver. It's like the silent scream of the liver. 1 of 3 kids in my state leaving middle school already has fatty liver. They're on their way to diabetes. Sleep apnea travels with that too. You aren't what you eat. I think this is one of the biggest fallacies kind of out there. None of us are what we eat. We are how our bodies metabolize what we ate. This is a concept too, I think it's important. So just understanding these carbohydrates. So if you check your glucose and it's 100, for example, that's milligrams of glucose, deciliter of blood. We have 5 liters of plasma volume. So if you do the cancellation out, you only have 5 grams of glucose in your bloodstream. That's 1 teaspoon, tightly regulated by insulin, 1 teaspoon. That's nothing. And if your body can regulate that, you're fine. But if it can't, you're heading toward diabetes and you're going to break your metabolic health, because this is like a constant siege, to render us out of homeostasis. So the modern living is a siege against our homeostasis, and this is that visceral adipose fat and all the conditions that travel with that, and this, everyone needs to know their own markers. This is that 88% unwell. How many of you here are completely normal in glucose, blood pressure, waist circumference, triglycerides, HDL? You got none of those things. If you have none of those things, Gerald Raven studied this, you might just die of nothing. People don't get anything. They don't have age-related diseases. The people that are highly insulin sensitive, these are the markers more specifically. These are the conditions. Joseph Kraft studied this extensively in the 70s. These are the insulin patterns. So your glucose might be okay, but if your insulin is shooting up, you are becoming diabetic. This is a glucose tolerance test and different patterns. So he would measure the insulin response and then match it with autopsy studies. And he called it diabetes in situ, and had this to say at the end of his career. He said, those who have diabetes, who say they do not have cardiovascular disease, are clearly undiagnosed. Meaning they just they don't know they have it. It's silent. A coronary artery calcium score can show this. I got a few more minutes, then we'll kind of go into questions. It's so much here to talk about. But okay, well, why do some people tolerate 30 teaspoons of sugar with every meal? A teenage football player, right? They're highly insulin sensitive. The muscle and liver are fine. They can throw a whole pizza in their body. Glucose goes up a little bit, insulin goes up a little bit, knocks on the door, stores it in the muscle and liver, go play football the next day. But as we go through life, stress, hormonal change, circadian mismatch, menopause, menopause, which happens in men, not quite as quickly as women. All the other unknowns that knowns that Vivian talked about, all those other markers of inflammation. Now you're carbohydrate intolerant. So now your liver's filled already with fat. You throw 30 teaspoons of sugar in your bloodstream. Now your glucose goes up, but now insulin has to start cranking up to clear the bloodstream, start cranking up. And as it does that, the resistance goes up. It's like tolerance. The more resistance, the more insulin on you go. This is Raven, right? So Gerald Raven, 1,000 scientific papers. So we look at type 2 diabetes and the complications of type 2 diabetes and the complications of high insulin state. So we kind of traditionally in medicine, we think of the type 2 complications as the high glucose, the glycation complications. This is retinopathy, kidney disease, neuropathy. But then there's the high insulin state. This is really that inflammation, that growth, hypertension, stroke, cancers, fatty liver, sleep apnea. So it's kind of a little bit of both. And cardiovascular disease is a micro and a macrovascular disease. So again, like all the stuff starts coming together when you understand insulin resistance. Again, more insulin, more carbs, more insulin, more resistance. It's like a vicious cycle. Now, to be able to release that fat, you got to get insulin really low, and then you can start making energy. So a health, I think, just think about this, and maybe this will be one of our final thoughts before questions. What is health? So a healthy body is what's called metabolically flexible. Okay, so that means when you need energy, you can make it from your own body, right? Think of old school days, right? You'd have dinner, you wouldn't snack at night. You'd wake up in the morning, and if you worked on a farm, you probably had to do 2 hours of chores before you had breakfast. So your body's making energy. Your insulin's low, you're making energy. That's how my body works. I wake up, I go for a run, and my body makes glucose. My highest sugars of the day are after a run, fasted, because my body's making glucose. Now, if you're metabolically broken and your insulin's up all day and we're giving you more insulin at night, that's probably the biggest catastrophe to modern diabetes care, are big doses of night insulin. Because if I'm giving you a lot of insulin at night, or you're snacking carbohydrates at night, your insulin is up all night. So when your body should be using fat as fuel, you can't, it's trapped. So you're needing to eat energy. You can't make it. So really important concept to understand. And everyone's going to have a little different level before this kind of dam breaks. A very muscular, athletic person might be able to have 100 grams of carbohydrates who's exercising 2 hours a day or has a physically active job, because they're just putting away the glucose, insulin independent. Now, if you have a retired 70-year-old who's sedentary needing a hip replacement, that might be a different story. Elephant in the room, insulin resistance. These are all the conditions that travel together. Preventing and reversing this, right? So eat real food, avoid processed food, avoid sugar, refined carbohydrates, vegetables, healthy fats. And obviously, what Vivian was talking about, the activity, sleep, and stress. Pure nutrition, I'll go to that. Yeah, so I mean, this is really it. Eat real foods, but you have to understand, if you have diabetes, those real foods can't be the sugary ones, so there's starchy and non-starchy vegetables. You want super nutrient dense foods, not just energy and calories over here. 60% of what Americans eat is ultra processed, and that's Michael Moss just wrote an amazing book called Hooked. Robert Lustig, Metabolical, 2 good reads that if you want to read about this. Now, people will kind of put you into a camp and they don't understand what you do. So they say, oh gosh, Mark thinks all carbs are bad. And that isn't true at all. Junk food is bad. So if you look at carbohydrates, they probably ate, going back, several generations. These were the carbohydrates, right? They're vegetables, fruits, roots, legumes, nuts. But now the carbohydrates are refined grains, and just junk food. So if we all did this, we would have been fine, but if we're not. How to make an obese anything? High fat, and high carb in the same meal. That's the Western diet, the processed diet. So they have a lot of carbs, raise the insulin. Then it's like a packaged muffin, right? It's like 600 calories, loaded with processed fats, loaded with white flour and sugar. So that just stores. So highly calorie dense, highly energy dense. You're going to store that. That's a school lunch. This is what happens in our schools. Carbs and fat together will break your metabolic health. We're at 4 o'clock. Maybe I'll just pause and stop there. Prioritize protein. The cost of protein is higher. So when we're looking at policy, we have to figure out how to advise and help people get good quality protein without super high cost. Time restricted eating. We could talk about this in the discussion where this fits in. Yeah, there's just so much cardiometabolic health with low carb diets. This will improve your cardiometabolic health, not make it worse. So eating the eggs and the healthy fats will not clog your arteries if you look at these parameters, cardiometabolic health. Medications, this will be, then we'll go to questions because I think this, just look at the slide. We could do this in the Q&As. So if you're treating people, you got to know which medicines to stop and lower because, and this is a paper we just published, because if you're on big doses of insulin and we tell you to stop your carbohydrates, but you're not willing to manage the meds, they can have complication. Obviously, they would get low blood sugar. So anyone who's having active management of carb reduction on medications needs a clinician who understands the medications. So if you're out there, a health coach or an allied health person who doesn't prescribe, you need to find a partner in your community. All right, we're done and we'll go to Q&A. I know it's a lot of stuff, but I know you go on for days about this stuff, but I hope I gave you just a little flavor. Didn't even get into the case studies, but hope I gave you a little flavor of the science.
This was wonderful. Thank you so much. And such a hopeful message. And it's such an important message that people need to know there is an option out there and that this can be reversed. And so, Jim, I'm going to turn it over to you now.